Moving on towards our next session, I'd first like to invite our chairperson, Dr. Bhavesh Parekh, Dr. Hemant Shukla, Dr. Niket Shah, and Dr. Sachin Vani. Next lecture will be taken by Dr. Harsh Dhar. He's Senior Consultant, Head and Neck Surgical Oncologist at Medica Super Speciality Hospital, Kolkata.
Would like to wish everyone a very warm morning and thank you to Dr. Kaustubh sir and Dr. Dushyant sir and the entire team here at HCG Ahmedabad for this opportunity. The topic that I'm going to be dealing with is kind of vast, so there are only very few select areas that I would be dealing with and concentrating on because it's very difficult to put everything within a short time. So in my opinion, the publications that have actually shaped laryngeal cancer treatment, and I'm sure that would be the consensus, in early larynx, it's the equivalence of the transoral endoscopic approach vis-a-vis the open partial as well as the radiation techniques. In locally advanced, in basically the T3 or the intermediate group, it's the evolution of the organ conservation approach and select few areas in the salvage settings such as management of the neck as well as use of a non-lay flap when doing a primary closure. So with that brief introduction, one of the very first articles or publication that comes to mind when we talk about the early glottic cancers is this beautiful description of the microscopic anatomy of the vocal cord by Hirano way back in 1974. And if you go through the paper, there's a lot of mathematics, a lot of physics formulas there which go way above the head. But what we need to focus on is the classification and the various layers of the vocal cord which have helped us define the classification of the chordectomies by the European Laryngological Society by Remakel. This was in 2000, and then a modification late in 2007. And we know the various subtypes. I'm not going to go too much into the depth, but subepithelial followed by subligamental, transmuscular, type 4 being the total. Type 5, you've got all the variations wherein you involve the false chord. Type B, you involve the posterior aspect of the arytenoid, and type C, the ventricle, and type D, the subglottis, and of course type 6, which is involvement of the anterior commissure. So this entire classification that we use for chordectomies has actually got its basis in the initial work which was produced by Hirano. And when we compare outcomes of transoral laser surgery vis-a-vis radiation, vis-a-vis open partial techniques, in terms of oncological outcomes as well as in terms of the voice outcomes, the classification of the type of chordectomy that has been performed becomes very important. So we go now to a few articles that have looked at the equivalence of the transoral laser approach. I've listed the various key meta-analysis and systematic reviews. So if you look at local control, right, majority of the studies show similar outcomes between the transoral laser vis-a-vis radiation. For local control, we do make the inference that transoral laser and radiation for T1, T2 do have equivalent oncological outcomes. Laryngeal preservation rates, definitely what we can see here is a majority of the meta-analysis favor the transoral laser approach because there is seen to be a slightly higher salvage rate with the RT arms. If you look at overall survival, while a few meta-analyses do show that outcomes are similar between the transoral laser approach and radiation, there are meta-analyses by Higgins and by Moore which have shown that the overall survival is better with the transoral laser. As far as voice outcomes are concerned, the issue is that majority of these meta-analysis and systematic reviews, the data being retrospective in nature, being heterogeneous in nature, the capture of voice outcomes has been very heterogeneous across all the series. But if you would want to make a summary, we could conclude that overall voice outcomes are comparable between type 1 and type 2 types of codectomies vis-a-vis RT. The moment you start doing a type 3, the voice outcomes with radiation are much better. This again, sir, is here. This is a very innovative study from the Brescia group. And what they had done is that they tried to map the site of the disease and look at its correlation with recurrence-free survival and organ conservation rates. And what they concluded was categories 5 and 6, wherein the tumor is involving significant amount of the paraglottic space, or with extensive involvement of the anterior commissure. These two categories perform the worst when we subject them to the transoral laser surgeries. So this is an innovative way of trying to select your patients for the transoral laser method. We come now to the very important subject of organ conservation in laryngeal cancer. And majority of the game-changing or the practice-changing publications have happened in T3 and in the intermediate group. So the organ conservation approach was aimed at achieving complete tumor response while preserving the laryngeal function. Evidence basically has emanated from the 3 main randomized trials and a few other subsequent trials. And the focus is slowly shifted towards functional organ preservation over time. And if you look at this a very beautiful summary and a practice guideline by the ASCO and headed by Arlene Forestier, the paper itself gives us a very nice consort diagram. And if you look at this red circle, the number of randomized trials are only 16, and majority of the studies that they have referred to are retrospective, 86. And I would like to thank Sir for pointing out this particular important entity. So the true game-changing publications are, I would classify them as the validation trials for induction chemotherapy, the V and the URTC, and the trials that looked at concurrent CTRT, the RTOG 9511, and the alternative chemo dose European trial. And the third would be the trials that have explored the role of docetaxel and cetuximab. But even before that, there are 2 parent trials from which the inspiration came, and these were headed by John Jacobs et al. And this is the first trial that came out in 1983, where a prospective study of 35 patients with stage 3, stage 4 head and neck cancers was subjected to 3 cycles of cisplatin 5-FU prior to surgery or RT. And 63% achieved complete response and 11% achieved a partial response with an overall objective response of 94%. So this was one of the first seminal papers that showed that induction chemotherapy can give a CR to the tune of 63%. And they followed this up with a correlation paper. That is, they correlated the response to chemotherapy with response to radiation, and there was significant response of radiation amongst patients who had undergone good response to prior induction chemotherapy. So with this surmise, we went on in the 2 initial validation trials, the VA trial and the EORTC, that showed that larynx can be preserved keeping equivalent oncological outcomes using non-surgical methodology. So a summary of the VA trial here: 332 patients, 166 in each arm, randomized to 2 cycles of platinum 5-FU vis-a-vis laryngectomy. After 2 cycles, there was a response assessment done, and if there was a partial response or a complete response, these went ahead with radiation vis-a-vis the other arm, which was laryngectomy followed by radiation. So the results, in a summary: the overall response to chemotherapy was 85%, with complete response seen in 31% of patients after 2 cycles. The larynx preservation rate in the induction arm was 64%, and the overall survival was equivalent in the two arms. Even on the 10-year follow-up, there was no difference in survival between the two arms, and the quality of life definitely was significantly better in patients with the preserved larynx. We'll go to the subsequent critical analysis of these papers a few slides later. So this was followed up by a similar trial within patients of hypopharynx. And here again, this is the EORTC 24891. 202 patients subjected to induction chemotherapy, complete response, and this was an important difference between the EORTC and the VA, whereas in the VA, even patients who underwent a partial response were selected further for the CTRT or for the RT arm, but in the EORTC arm, the selection criteria was much more stringent, and only patients who had undergone a complete response were further taken up for radiation. The results: 3-year overall survival was comparable, the 3-year and the 5 years. Larynx was preserved at 3 years in 42% patients and at 5 years in 35% patients. They did subsequently calculate the laryngectomy-free survival, which was 28% at 3 years in the induction chemotherapy arm. So this was a purely hypopharynx trial, and a lot of modern treatment that we use, the arm of induction chemotherapy followed by patient selection for the next CTRT, has emanated from the EORTC trial. There are multiple issues with interpreting these trial results, and this is a very good paper by Dr. Mitali and by Dr. De Cruz, wherein you've got variable endpoints. The other important aspect is translating these randomized trials to general clinical practice and to the normal patients which are out of trial, and the kind of care that we are able to provide. Conclusion of both these trials was basically, this was the first time that with induction chemotherapy followed by radiation, we showed that the larynx can be preserved, keeping oncological outcomes same as a laryngectomy. Now, what is the ideal endpoint? And the various endpoints that have been used in the early trials, one was larynx preservation rate. And for the youngsters, it's important to understand larynx preservation rate looks at whether or not the patient underwent laryngectomy, full stop. The disease status and survival are not accounted for. The other common endpoint was laryngectomy-free survival, and that looks at whether the patient is alive without having to undergo laryngectomy. And here again, the disease status and functionality have not been accounted for. And having understood this and realized this, this is a very important consensus paper that came into being led by Ang, and they defined a non-functional larynx by these 3 criteria: severe dysphagia necessitating a feeding tube, evidence of pneumonia, and a tracheostomy. And subsequently, the recommendation came that we need to have a composite endpoint of a functional larynx in addition to survival and larynx preservation. So the composite endpoint that was termed as laryngo-esophageal dysfunction-free survival. And they recommended that a mandatory baseline assessment of swallowing prior to deciding the treatment protocol is very essential. We then go to the trials looking at CTRT, and this of course is the, we have the RTOG 95, the RTOG 9111. This actually started in 1992, a multi-center prospective randomized trial to compare 3 arms: chemoradiation, induction chemotherapy, and radiotherapy. The inclusion criteria, having learned the lessons from the VA and the EORTC, the inclusion criteria was quite stringent. This is limited to stage 3, stage 4 operable tumors with a performance status of more than 60. Exclusion criteria, T1 lesions and of course bulky T4 with gross cartilage erosion were excluded, which were present in the VA trial. So 547 patients, induction chemotherapy, chemoradiation, and radiation. Important to realize that a surgical arm is missing from this trial, and that has been a major criticism of this trial going forward. So the trial schema was quite similar in the induction arm to the earlier trials. We go to the results, and if you look at laryngectomy-free survival and the 5-year estimated OS, more or less were similar across the three arms. Laryngeal preservation was highest with the concurrent CTRT at 84%. Salvage total laryngectomies were lowest with the concurrent CTRT, that's 16%. Salvage TL was 28% in the induction arm and 31% in the radiation arm. So this was the initial report. That's the first report, right? So this proved that concurrent CTRT was superior to induction chemo-RT and radiation as in terms of laryngeal preservation. Again, important to note that functional laryngeal preservation was not noted here. Drawbacks, again, no surgical arm included. And the primary endpoint of the trial was laryngeal preservation rate and not OS. The long-term results were interesting, and they have forced us to look at concomitant chemoradiation through the microscope. And this again was because of the publication of the McKinsey and a subset analysis of 3 important trials from the RTOG group, which showed that 43% late toxicity was seen in patients who undergo chemoradiation. So the long-term outcomes actually showed that chemoradiation still had higher larynx preservation rates at 81.7% as compared to the induction arm. Laryngectomy-free survival, there was no significant difference. However, the overall survival, the long-term overall survival was higher in favor of induction chemotherapy followed by radiation, and a lot of this was postulated to be because of long-term treatment-related complications in the chemo-RT arm. This is a very interesting pictorial representation of the long-term outcomes between the chemo-RT arms and the induction chemo-RT arms, and this table has been taken from an analysis of the DELOS-2 trial. If you look at the green, the green represents patients who are alive with larynx. So that is again higher in the induction chemo-RT arm at 28.9%. The dark gray represents people who are dead without laryngectomy. The light gray represents people who are dead after laryngectomy, right? So that again shows that the incidence of TL, that is a salvage laryngectomy, though higher in the induction chemo arm, however, the overall survival is higher in the induction arm vis-a-vis the chemo-RT arm. So I just showed this because of the way that they have represented this, making it easy for us to understand the results of the long-term results of the RTOG 9111. Next, we go to the few trials that have explored the role of addition of docetaxel and cetuximab, and this, of course, emanated from the TAX 324, wherein they showed that TPF over PF showed significantly better OS and progression-free survival. And if you look at a subset analysis of the TAX 324, there is a subset analysis that shows that larynx subsite favored largely over the hypopharynx subsite as far as the TPF is concerned. We go now to the DELOS trial, and why we are talking about the DELOS trial, though this has not been exactly practice changing. So here, this was an addition of cetuximab to TPF. So patients were randomized to 2 arms, induction with TPF vis-a-vis induction with TPF and cetuximab. Response assessment, interestingly, was done after induction chemotherapy at week 4, and they have used a term endoscopy estimated tumor surface shrinkage. And if this was more than 30%, only then did the patient undergo further cycles of induction and RT. So they used the endoscopy-based tumor shrinkage more than 30% as a selection criteria for going ahead with the organ conservation approach. And a subsequent analysis of the DELOS-2 patients, they have tried to come up with a nomogram wherein they have looked at various factors. One of them, of course, is the tumor shrinkage. Apart from that, they have looked at the presence of 2 or more nodes. They have looked at residual tumor volume if it is more or less than 20%. They have looked at residual volume in terms of in the terms of volumetric analysis, as well as the ratio between SUV max and SUV mean on the response assessment. And they have tried to form something known as a laryngo score or an LFS score. So if the LFS score is less than 16, then it would predict that the patient would do much better with an organ conservation approach. So this is just to stimulate us and just what's new on the horizon. If we look at, how much time do I have? 30 seconds, sorry. So if you look at factors that have affected response, performance status of the patient, comorbidities are important factors. Apart from that, T4 and cord fixicity. So if you look at the VA trial and the RTOG, T4 cancers accounted for 54% of T4 cancers within the VA trial actually required a total laryngectomy. And as opposed to that, the RTOG had T4 cancers where they were T4 based on involvement of the base tongue and not because of cartilage erosion. If you look at cord fixicity, this again, I'll just take 2 minutes to complete. Cord fixicity again was an important factor that could predict response to chemoradiation. And if you look at the analysis of the RTOG 9111, based upon the fixity of the cords, 35.3% in the induction arm, 18.3% of the chemo-RT arm, and 31% of the radiation arm. So basically, cord fixity could again predict the need for a salvage laryngectomy. I will go further to the salvage setting and a few important studies here addressing the neck in the salvage laryngectomy setting. So with the results of the PET neck trial, we do know that a negative uptake on the response assessment scan bodes very well, has a very high negative predictive value for an N0 neck. So the philosophy that you could use is to avoid a neck dissection if there is no uptake in the neck on PET. However, a caution for N3, because the N3 has not been well represented in the PET neck study, and we may not be wrong if we offer an elective neck dissection to tumors which were N3 on the pre-treatment scans. And lastly, use of onlay flaps in the salvage setting. There are multiple meta-analysis and systematic reviews which have shown that there is some benefit of using an onlay PMMF flap when we are doing a primary closure. There is a randomized trial underway at TMS Mumbai at present, and this came from an important retrospective study conducted by Dr. Shilpi Sharma there wherein we showed in a large series of 110 patients that using an onlay PMMF, though it does not reduce the fistula rates, but it then does improve the hospital stay for these patients and improves the recovery time. So with that, I would end. I'm really sorry for not being able to include many other important aspects such as the tracheoesophageal prosthesis, which again has changed the way that patients of laryngectomy are managed. So this is the team that I work with, and thank you to the entire audience. Thank you for this opportunity.